are so fortunate to have very rich panel to discuss this very important topic today. So with me here, I have Dr. Iseko, and joining us will be Dr. Edafe.
Dr. Edafe, can you say hello?
Hello. Hi.
Hello, we can't hear you. Speak up.
Yes, I said thank you.
Good to have you on, sir. And I believe our people will enjoy today's discussion. Then later, we have another panelist join us, an interventional cardiologist joining us from the United States to also add some comments to today's discussion. And today, we'll be taking a very important topic, which in later we can refer to as heart attack. All this will go into detail by the time we're going into the meat of the discussion. And we're coming live from Cardiovascular Multispecialty Hospital, Area 11, Garki, Abuja. And like I said, today we'll be talking about how to diagnose and how to manage a patient with myocardial infarction. So, Dr. Iseko, let's start from home before we go far. So, what's myocardial infarction?
Okay, thank you very much, Dr. Oleko. I'm very happy to be here. I've not presented in a while, so I'm very happy to be here. And I'm happy to be here with Professor Edafe. Just to remind you that Cardio Care is bringing this webinar free to medical doctors around Nigeria, and the vision is to empower Africa through healthcare treatment. We typically have quite a rich presentation, and I'm happy to be here. So straight to your question, what is myocardial infarction? So myocardial infarction essentially is defined by two critical things. The first thing is the presence of active myocardial injury. Okay. Number two is that active myocardial injury occurs in the evidence of myocardial ischemia. So you can't have one without the other before you call it myocardial infarction. There must be myocardial injury, which we typically find by cardiac biomarkers. And number two, it must happen in the setting of myocardial ischemia.
So, in another word, you are telling us that it is almost impossible to make a diagnosis of myocardial infarction without finding cardiac biomarkers.
It is almost impossible. Of course, you can still try, but this is the standard universal definition of myocardial infarction. And it involves that you need cardiac biomarkers, you need evidence that shows that there is cardiac ischemia. What are the evidence of ischemia? Now that you ask me, okay, I have high troponin, but do I have evidence of ischemia? Evidence of ischemia is defined either as a symptom of ischemia, it can be chest pain, ECG changes, new development of pathological Q waves or left bundle branch block, or imaging evidence of infarction, that is on echo, on PET scan, on MRI, any evidence of that. So sometimes, because the world is vast and there are many that don't have an ECG. If you don't have an ECG, but you have significant clinical suspicion and symptoms, and you have a biomarker, it can be taken. But if you don't have an ECG, you don't have biomarkers, then your diagnosis of cardiac or myocardial infarction essentially will be suspicious or just be a suspicion, not confirmed.
But with that suspicion, people can still quickly send to a place where all these things can be quickly done to ascertain what the patient really has, rather than just keeping the patient back.
Yes, myocardial infarction is a deadly disease, and everybody must know that it's a medical emergency. If you have a patient coming with a heart attack, with chest pain, with changes on the ECG, and we'll explain those changes on the ECG, with elevated troponins or biomarkers, you must realize that you are dealing with a life-threatening event and that you should treat it as such. We have had cases whereby people treat them as ulcer or something, and just instead of getting the input of a specialist as soon as possible. So if you cannot make the diagnosis, or you have made the diagnosis, thankfully, and that's if you are here today, you should, at the end of this, you should be able to make the diagnosis. If you've made the diagnosis, then you should make sure that you complete that diagnosis by getting biomarkers or an ECG and reported ECG.
So we can now say the tools that we need to really make a diagnosis of myocardial infarction include a good symptoms, ECG, cardiac biomarker.
Yes, definitely. So it is impossible to do and to make a diagnosis without the ECG. It's impossible to make it without history. It is impossible to make it without cardiac enzymes. Now, if you have an echo, that is also an addition. And if you have coronary angio, that is super, because now you can confirm it. I don't know what Dr. Edafe, I don't know if Dr. Edafe has anything to say about this. Dr. Edafe?
Hello, Dr. Edafe, are you there?
Yes, I'm here, sir. Very correct. I agree with you that in the process, one has to distinguish between myocardial injury and myocardial infarction, because there are many things that cause injury to the heart. There was one of the slides that Dr. Seko rightly showed. Yes, this is the slide. Very correct. So for you to describe myocardial infarction, there have to be a process of ischemia. Now, this process of ischemia results from atherosclerosis, oxygen demand and supply imbalance. But you also have other things that also cause injury to the heart, which are not necessarily myocardial infarction. Things like myocarditis, things like vasospasm. All these things can also occur and injury can also result. There are things like chronic ischemia, like stable stable angina that has chronic stable angina that has lasted for a long time. And if you really do perfusion imaging for this group of people, you will find out that there is evidence of myocardial injury. But if you check their troponin and check their other cardiac enzymes like CKMB, FDH, and myoglobin, they are normal. But you still have that there is evidence of myocardial infarction. So Dr. Seko is very right. I think we are all in the right track. Then the other thing to add is that there is another certain group of people, although very minor, we call them myocardial infarction with non-obstructive coronary artery. Now, you have evidence that there is elevated troponin. The ECG there is also significant changes on the ECG. When you go and do the coronary angiogram, you find out that there is no significant obstructions in the coronary artery. We group those people as minocardial. Now, it's an entity that is now widely accepted in the guidelines. And this group of people, things like we theorize them are things like vasospasm, maybe there was a clot and it dissolved on its own, or maybe there is inflammation of the endothelial lining of the arteries that causes all this and the rest of them. So these are a group of people that fell into the minocardial group of people. So Dr. Seko, we are really listening to you. Thank you for the update. Go ahead, sir.
Thank you very much for that rich contribution. So
I will also try and emphasize. So a lot of times, why did we define myocardial infarction as 1, biomarkers, and 2, ischemia? Because there are cases where you can have biomarkers elevated without it being myocardial infarction. And there are cases where you can have ischemic symptoms without it. So that to make a full diagnosis, you need it. And that is what we see here. It's very important that as a clinician, you differentiate between these two. Number 1, if you have an elevated troponin level or cardiac biomarkers, of course, troponin is probably one of the most sensitive for myocardial injury. So now if you have it in the setting and there is no, without acute ischemia, typically active myocardial injury could have occurred. Trauma, heart failure, myocarditis. Sometimes people even have it in the setting of stroke, embolism, renal failure. Those are other things that can cause it. Now, in the setting of ischemia now is where we are particular about. whereby you have acute myocardial infarction, which will be either from atherosclerosis or from imbalance of supply.
Yes.
Okay.
So that will now take us to the different type from the universal definition of defining myocardial injury from different type, looking from type 1 to type 5. And I think this is what our people can read from the slide. So we've talked about the symptom, we talked about biomarker, and we also talked about ECG. I think it is good to tell our people what's the key things on ECG change that suggests myocardial ischemia.
Thank you very much. So let me just add by saying, if you have a question while we are talking, just write it into the Q&A box so that we can get back to them as soon as we get them. Or raise your hands and then we'll call you later on. But put inside the Q&A box with your question. Now, the findings suggestive of active myocardial ischemia are critical. And these findings essentially are those of a new ST segment elevation. We put that word new name. Number one, the ST elevation must not occur in isolation. It must occur in what we call contiguous leads. What does that mean? Like we're speaking big grammar. It means that if two of us are looking in this direction, both of us will have the same thing to say. So out of the ECG leads, they are grouped in a way that one or two ECG leads are looking at the same area. Once two people are they say at the voice of two witnesses, a matter is confirmed. So once you have two or more ECG leads showing an ST elevation, then that more or less confirms it. And how do you define ST elevation? If it's greater than 1 mm, that's one small box. That is significant. However, in V2 to V3, it should be a little bit more. You know, so before you can quickly say a difference between male and female. Also, you have to consider ST depression and T-wave changes. Typically, new horizontal or downsloping is greater than 0.5 mm in two contiguous leads, or T-wave inversion more than 1 mm. There's also
Q waves, are they still important?
Q waves are very important. Q waves are very important, and Q waves, you also look at it also. Any Q wave, you know, in the V2 to V bigger than 0.02 seconds. That is bigger than one small box. Okay, and QS is very significant. If you have these Q waves, now how do you define a Q wave? A Q wave is defined as the first negative deflection after a P wave. So once you see the P wave, look for the first negative deflection. If you have this occurring, especially in contiguous leads, and you talk about contiguous leads 1, AVL, B5, B6, B1 to B4, B1, B2, B3, B3 to AVF. If you have these Q waves, then typically you will say that it's significant. Now, you must remember the caveats. In a bundle branch block, it can be difficult to differentiate. It can be quite difficult to put aside. However, it is still very possible to do so, and we'll talk about that later on.
And for someone having that you have opportunity of seeing an old ECG and you see something that looks like a new left bundle branch block in the context of what we've discussed is also a significant finding. Thank you very much for that. And later we'll get to see some of this picture, and this thing will become much more evident to us. Then I quickly want us to differentiate what, people say there's heart attack, there's acute coronary syndrome, there's ischemic disease, stable angina. How do we differentiate all these terms?
Okay, fine. So a lot of patients will come in and say, Doc, I don't know if I'm having heart attack. And we have to differentiate cardiac arrest, heart attack, heart failure. Okay, even among doctors, sometimes there's some confusion with these terms. A cardiac arrest means that there is cessation of cardiac activity, for whatever reason, and that could be all effective cardiac activity. That's cardiac arrest. In a heart attack, what essentially means that there's a myocardial infarction, or there is reduction in blood flow to certain parts of the heart, and it spans across, and we have tried to define a myocardial infarction. In what is termed an acute coronary syndrome, it means that in cases like this, and I will show a slide to help buttress this. It means that in if you look at this lumen of a normal, if you see a normal lumen here, what typically happens in the normal lumen is that it's clear like this. Then people could have atherosclerotic plaque. And this can now progress onto what we call a stable plaque. Now, once this stable plaque is disrupted, what essentially happens is that patients now have severe ongoing chest pain. This chest pain now can give rise to three significant things, but we must treat all of them as an umbrella body called acute coronary syndrome. Okay, and today we are talking mainly about ST segment elevation MI and non-ST segment MI, meaning myocardial infarction, in which case there is significant obstruction of the lumen and
presence of cardiac biomarkers.
Exactly.
Like one of my teachers used to say then that talking about cardiac arrest and atrial, that's cardiac arrest, that's looking at it like a house. That cardiac arrest is largely an electrical problem, while heart attack is like your pipe problem, your pipe blocking. But we also know that they are both related in one way or the other. Thanks for that clarification. We've talked a little about the ECG. Can we also now talk about the symptom we talked about? We talked about the symptom. So is it that any chest pain, once there is chest pain, there is a myocardial infarction?
Okay, fine. Chest pain. So we'll go into chest pain. And perhaps at the end of this presentation, we'll send you the CardioCare chest pain algorithm that you can use in your clinical practice to help you differentiate when somebody comes with chest pain. Chest pain, every time somebody comes with myocardial infarction, there are presentation profiles. Chest pain is typically the most common one and the most common symptom. However, some people may not come with chest pain. Some people may come with complications. They come with acute pulmonary edema, with heart failure, with arrhythmias, and that may be the opportunity for you to make the diagnosis. Some other people will come with a silent MI, so they come with other things, and in the process, you find out that they're having a heart attack or sudden cardiac death is a presentation of myocardial infarction, and so all these things. So when patients come with chest pain, there are three major criteria to evaluate them. Very simple history criteria. Number one, where is the chest pain? Is it left-sided or substernal? Number two, is this chest pain brought on by emotion or exertion? And number three, is it relieved by rest or catheterization? These three characteristics help us to define the chest pain. Typically, if you have all three being positive, we will say it is a typical chest pain. It is more often than not, most patients coming with chest pain in myocardial infarction will have been having this kind of typical chest pain in the past. And then at the time they come, they have come with a frank myocardial infarction. And then we'll say a typical chest pain when it's only two of these that are positive. And if only one of these is positive, then non-cardiac chest pain. However, it does not rule out the presence of myocardial infarction. So the other things that you ask in your history, what are the other things you ask? Where is it? Are there any aggravating factors, relieving factors to define those three? How long has the chest pain been? Now, in myocardial infarction, you have prolonged chest pain. While in angina, you have chest pain coming and going. Typically, in patients having myocardial infarction, it's rare that they have chest pain, they went to work, they went to market, they continue that. It's very rare. More often than not, they have diaphoresis, they have dizziness, but they also have cardiovascular risk factors.
So, like pain in there for almost 2 days.
Or 2 weeks, or the last 2 months, I've been having one chest pain. Sometimes I take paracetamol and it goes. It's less likely. It's less likely. Those are things that should be considered.
But which group of patients are likely to have the silent ischemia you talked about?
So the people that normally have the silent ischemia, that is, they're having a myocardial infarction.
But there's no pain.
There's no pain. They are having, maybe they just start sweating, they just start having dizziness. Which is why it's very important in people that have appropriate risk factors to have an ECG when they are coming with abnormal symptoms or non-specific. So the people that typically
attack,
exactly,
just feeling tired, sweating.
Those people are typically women, people that have diabetes, or people that are a little bit elderly. A lot of times they have problems with sometimes they even come with another pain, and the nerve.
Okay. So, Dr. Edafe, do you have anything to add to that, sir?
Okay. Thank you very much, sir. Great discussion, Dr. Seko. The little to add to it is on the ECG. When you look at the ECG, you know we talk about STEMI and not STEMI based on the diagnosis on the ECG. Now, there are a group of people, for example, those that are going for exam should know this, that if a patient has posterior wall infarction, it is classified as STEMI, but on the ECG, it's going to be SE segment depression in V1 and V2. That is not a non-STEMI, it is STEMI. Then number two is that the use of new onset LBB. Before now, we thought that it is equivalent of a STEMI, but most studies have come up and tried to debunk it. So the guideline has made some changes in the sense that new onset MBB is no longer equivalent of myocardial infarction, because you can see people with a dilated chamber. All the chambers are dilated and the contractilities are poor, and they may have a new onset MBB. Then two, you must also see people with a very infiltrative disorder, and they may also come down with it. Or you may also see some people with a hypertrophic event, a hypertrophic heart, and they also come down with a new with LBB. So because of this confusion, the guideline now say that a new onset LBB is not equal, is no longer equal to MI for now. Then the other thing is
but we still advise people to still look out for the MI.
Yes, look out for it. Yes,
you have a do the cardiac enzyme, and still don't just take this, because that is in Nigeria. The person come with me also, that may be the last time you are seeing him. So try and also still investigate, even though guidelines are changing somewhat.
Very correct, sir. Very correct. Then atypical presentation is also common in our environment, as Dr. Seko stressed here. Atypical presentation in the sense that they may just, for example, inferior infarction, they just come down with epigastric pain and or epigastric discomfort. So when we have that, just as we said, always look for the risk factors. If the risk factors are present, things like diabetes, things like hypertension, dyslipidemia, smoking, and the rest. If all these are there, don't end the patient up with a diagnosis of peptic ulcer disease, but rather evaluate the patient further, because it may just be an MI with atypical presentation. So, Dr. Seko, go ahead with the rich discussion.
Thank you very much, sir.
Let me just point out, I can see some questions in the box asking about certificates. So typically we get certificates to the email that you registered with. If we check the attendance and your presentation and you are present throughout, we typically will get a certificate to your email address. If, however, you don't get a certificate, please check your spam. And if you still don't get it, please write us back on the email the email that gave you the registration link. Just write us back. And someone asked about the recording. The slides also, you get the slides as well. And then the recording will also be here on our YouTube channel. And there are plenty of other recordings which I advise you to go back. How to ECG, an ECG, BLS, chest pain. We had a 2-hour discussion on chest pain and how to differentiate chest pain. So go there, Dr. Olalekon did good just to that topic. So it's quite important that you go there, very simple to understand, and get them together. So the recordings are here, just for the people that are asking questions in the chat. Okay.
I think we should just quickly talk about this our algorithm.
So let me quickly show you this algorithm. If a patient comes, this is our algorithm in the hospital group, which is very helpful. It's a single-page algorithm. You can have this in your consult room, and we'll try and send a PDF copy to you so that you can easily use. Now, all you simply do is first, the patient has come with a chest pain. In this regard, if you are unsure, please refer to a specialist. However, do a 12-lead ECG. Now, like Dr. Edafe said, the patient also presenting with severe epigastric pain, like it's ulcer, especially if they have risk factors. Please do an ECG. Don't just assume it's ulcer.
We've seen so many like that. Treated for peptic ulcer disease, and then at the end of the day, major coronary artery.
It's very, even among medical doctors, they are having a heart attack and they are drinking antacids. So it's very important if you're having that kind of, please do an ECG. Okay, now if within 10 minutes an ECG should be done. Now, immediately clinically evaluate, we'll talk about the evaluation, and then do a cardiovascular risk profile for anybody presenting with chest. Now, the next question you need to ask yourself is, does this person have a high cardiovascular risk, or intermediate cardiovascular risk, or low risk? If they have a high risk and their ECG is normal and they are still having chest pain, please repeat chest ECG. We guys actually say every 15 minutes or 20 minutes. So you may admit that patient, put on a cardiac monitor, and look at the ECG and repeat the 12-lead ECG shortly. If there are abnormal ECG, please go on straight to do an echo and a troponin, especially if there's ongoing chest pain. This will help you. So you can see that it's very easy to follow the algorithm and decide what to do, the path to follow through all of this. And so what do we do next? The next thing we do now is to, if the patient is an intermediate risk, that patient has only one risk factor, very hypertensive or something, diabetic, you know, dyslipidemia. Now you do your ECG immediately. The next question somebody will ask me is, I am in one village, I don't have an ECG in my hospital, how can I treat myocardial infarction? The answer is you cannot. You need an ECG. Yeah. You know, go and get it. Consider ECG like a stethoscope. It is critical in the day and age you are living in. We've had so many stories of sudden cardiac deaths, so many people waking up, even the recent pastor that woke up and did not wake up in the morning. Those are things that we should really be looking out for. Okay, so we have check their blood, the ECG. If immediately do troponin after that. If the troponin is still normal, so troponin is normal, you know, you may consider repeating the troponin. This is why you must consider repeating the troponin. Troponins get elevated within 6 hours of an MI. So if you do an ECG at the start of a troponin at the start, it may still be relatively normal, yes, which is why you may have to repeat your troponin in 12 to 24 hours. Yes, some of these things are a little bit costly, but they are critical to life, and there's no value that you can place on life. Now you can now go on. You now have a positive troponin. If you have a positive troponin with a normal abnormal ECG, especially with the ongoing chest pain, like we talked about, automatically we have fulfilled the diagnosis criteria.
At least two of criteria.
At least two of the criteria. Make sure you get specialist input and admit to an ICU or CCU. Begin to stimulate your cath lab, which is close to you. You can get one in cardio care. Or in this day and age, COVID has become important. It has become important because of patients come with chest pain, you could have a pulmonary embolism, you could have something else, troponin is elevated, you know, and you begin to do that. So these are some of the things that you should look at and just follow the algorithm. It will guide you necessarily.
And for those with low risk, we should not forget the non-cardiac cause of chest pain. We should not say because we've discussed chest pain and not say we'll not forget every other thing and say all chest pain is myocardial infarction. We should look at our patients holistically.
And even there are people with no risk that come with MI.
Yes.
So don't assume that somebody has low risk, but the patient doesn't have hypertension, diabetes.
An example is one of our recent Asian, not a non-hypertensive, not diabetic, not obese, and had significant lesion in the left anterior descending.
In fact, they had 2 lesions in the same artery and came with severe chest pain, a foreigner. In fact, it's still on admission now. Quite significant. Now, the doctors referred a little bit late because they were thinking, okay, maybe. But if they had said everybody with a chest pain must have an ECG, they probably would have picked it up early. And if you're not sure, you can also send it to us to help you with this.
Let's answer this question before we leave and go to the diagram. Somebody is asking, what is the implication of that Q wave on the ECG?
Okay, so what is the implication of a Q wave on the ECG? And a Q wave typically implies, and that's Dr. Osulanja, the Q wave typically implies that there is transmural infarction. What do you mean by transmural? Let's assume this my phone is the heart wall. It implies that the infarction has gone all through. Exactly. You know, it has gone all through the thickness of the heart wall a lot of times. Okay, now you look at that. Yes, there are instances where you could have it and there will be nothing there, but you must think, especially it's coming to a new onset fluid. And if you see our previous description of MI, you will see that we also talk, especially with the European Society of Cardiology, abnormal Q waves, typically signify an unrecognized MI. Now, if the patient is also coming late with an MI, they could have had the ST segment elevation and later it would have come down.
It's only the Q wave that you just find.
In fact, the last two patients we had with MI that we went to the cath lab and opened up their vessels all already had Q wave that they represent. They find a great presentation.
Okay, so let's just show people. Someone is also asking us to show ECGs. So maybe we can just take our listener through what to look for.
Okay, so I will advise everyone watching, go to our YouTube channel and just Google cardio care. We'll also put the link of the YouTube channel. Pamela, please put the link of the channel on the chat for them, so that it can really help. Now, if you look at this ECG we are looking at here in front, what you are looking for is this point 2. This point 2 here, where the arrow is. That point 2 typically signifies that point 2 where the red arrow is. That point 2 is the point of the ST segment. This is the point you use to check the ST segment. Now, if you look at it, you will see this is the level of the ST segment, and compare it with the level of the so this level of the ST segment, you can see that, and you can compare it with the level of the Q wave. Now, if you look at this TP line, let me see if I can show it very well. How do I do that? Okay, now you can see my pointer. If you look at this line, this TP line, the line between the T wave and the P wave, that is the line that is considered the baseline. Compare this line, take it all the way to this ST segment, this J point that we've talked about. So this is about 2 boxes, and this is we say this is ST elevation. Now, of course, you need to look at it in contiguous lead. So you need to look at it that, okay, this person said that Dr. Eseko has a lot of money. There's another person saying, when 2 people have said it, then we are now agreed. So 2 people that equally have ability to see that same area are considered. So you look at it, that same point compared to the isoelectric line, when it is elevated, you see the ST elevation. Every doctor, I repeat, every doctor must be able to identify an ST segment elevation MI on an ECG. Every doctor. If you cannot, please go back and watch our ECG presentation, and perhaps we'll still talk about it again and again. We'll send you this slide so that you can look at it and keep it as something to reference. Look at the ST segment here, like we talked about, compared to these ones, and you can identify it. Even your nurses and your ECG technician should be able to identify this ST segment elevation. Now, sometimes you could have ST segment depression, like you have in STEMIs, and sometimes you could have that Q wave. Now you can see the Q wave. The Q wave is the first negative deflection after the P wave. Now, if you have those Q waves there that are typically more than a quarter of the R wave, it's quite important to look at that. Now, remember that it must be present in at least 2 contiguous leads. So 2 of these leads together must show this ST segment elevation, and it's quite important for us to note.
Okay, we should also qualify the shape of the ST segment elevation.
I don't know if we have
it's also on this.
Yes, good. Okay, fine. So you can see the ST segment elevation. ST segment here is flat. In this case, you can see it is concave down. This is what we call concave down, and what is concave up. In a concave up, that means that it's like a saddleback. Somebody can sit on it. Okay?
Like a spoon.
Exactly like a spoon. In this kind of one, it's elevated, but you should be careful about pericarditis, whether you're not dealing with pericarditis. You have a segment elevation everywhere. Not in any particular, just everywhere. or if it's concave up, and it's quite important to look at this. Now, we're talking about left bundle branch block, and which Dr. Odafe already alluded to. There is a Scarbosa's criteria which you can use. Left bundle branch block is quite serious, and
it's quite difficult because once people see that ECG, they say, "Oh, what it is?"
So when you say left bundle branch block, you should look at this criteria. If the ST segment elevation is greater than 1 mm in QRS, concordant, this is a concordant ST segment elevation, meaning that this ST segment is in the same direction as the QRS component. If it is 1 mm and above, then we say we give 5 points. If, however, the ST segment elevation is greater than, there's a depression like this one, and that depression in V1, V2, or V3 is more than 1 mm, we give 2 points. Now, if you have ST segment elevation like this is the typical how you see the left bundle branch block. But if its elevation is more than 5 mm, then you will give it 1 point. And this typically is enough. Sorry, the slide is looking, some part of the slide are cut short. So if this, you see this one, then you can now define as likely you are having a myocardial infarction.
Okay, thank you very much for that beautiful explanation of the ECG. And we should not forget that we've been talking about how to recognize a patient that has myocardial infarction, and we talked about having the typical symptoms in the setting of a myocardial injury that is confirmed by the presence of a cardiac biomarker. And we've also been able to establish the fact that apart from patient just presenting with these typical symptoms, patient can also come with complications.
Very, 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 very important. So very important. And that's why we talked about the clinical profiles of a patient presenting with myocardial infarction. That sometimes they may come just with chest pain. I'll talk about the chest pain. Sometimes they may come just with chest pain. Sometimes patients are coming with pulmonary edema. They're coming breathless, crepitations everywhere. You should immediately consider that the myocardial infarction is possible. Sometimes they're coming with sudden collapse or sometimes they're coming with sudden cardiac arrest and you have to resuscitate.
And some are even coming with arrhythmia.
Yes, a lot of arrhythmia. And that's one of the things you have to guard against. Dr. Daphne, I don't know if you have anything to add again in this regard we talked about so far.
Yes, regarding the complications, sir, very correct. As you said, thank you very much, Dr. Seko. Excellent discussion. Some of the complications, as you rightly mentioned, they can come down with heart block. We have seen them in the cath lab, several of them. Sometimes the first thing that they just, apart from the chest pain, they can just present with ventricular tachycardia. We have seen them also in the cath lab. Ventricular fibrillation, we have also seen them. These are electrical activities that occur because of the wide area of infarct and the injury to the cells. Then also ventricular aneurysms we have also seen them. Then as due to the aneurysm, because the heart is no more contracting well, clots also do form in the process. So I've seen all these that do come down as a result of myocardial infarction. So Dr. Seko, excellent presentation. Then the other thing I just needed to add is that the Garbosa criteria is used for, apart from LBB, it's also used for ROBB, also to define patient with infarction, also used for people with ventricular atopy, because MI can also present with ventricular atopy to define infarction or any other arrhythmia that occur. As long as it's not a sinus reading, it's difficult to interpret the ECG on the basis of ST segment depression or elevation. So you use the Garbosa criteria to define it out. And as we said, the cardiac enzymes and other things that you do also help you, and you move the patient to the cath lab straight away to meet up with the requirement of the timing of the hour. Thank you, sir.
Very, very, very important, especially in the pace reading. Sometimes you have a pace reading, patient is not with chest pain, patient on a pacemaker, and you're also wondering whether this is there. So if you use this Garbosa criteria, essentially look at the ST wave, ST segment and the T wave. Check that is it in the same direction as the QRS complex. Once you are seeing the same direction as QRS complex, your mind should start focusing already. Now, if you have ST depression and that depression is happening, like we are seeing in this slide, then that should now be also something that we'll look at it. Now, it is said that the Cabosa criteria, based on the studies done, have almost a 90% specificity and positive predictive value, and that's quite important. That's right. Yes, you need to help us.
Thank you, sir. Very important.
Thank you, sir.
Let me just show some ECGs. Somebody has asked about ECGs. These are ECGs from cardio care or patients that are presented. If after this presentation, if you go back and you think back as a doctor, you probably will have seen some patients with an MI. If you look at this ECG, what can you see? We can see the patient with the sinus bleeding. We have done an ECG class here already, so especially in the cardiovascular consultation. And what else can you see? Can anybody see any ST segment elevation? If you can't, just write in the chat box if you can see any ST segment elevation.
Is anybody trying?
Is anybody trying? If you can, somebody raise their hand. Should we take, okay?
Maybe you should check.
Yes, Isa, Dr. Isa. Of course, Dr. Isa.
We are not asking you.
So that's the cardiologist. Okay, fine. So we can see the ST segment elevation in certain areas, and okay, I can see other people saying in Dr. Coker says in the 2, 3, and AVF. Exactly.
Okay, that's good.
Exactly. So we're talking about the ST segment elevation in the 2, in the 3, and in the AVF. So you can see that in the 2, the 3, and in AVF. Okay, see the lead 2. Can you see the TP wave we talked about? So this is a real life ECG. So sometimes we've always had people that say, we finish teaching this ECG. When they go back, they see a normal ECG, they cannot take it. So you can see this one, see the TP line, and see the ST segment. You can see that the difference is about 3 boxes.
Yes.
Now we said it must be in contiguous leads. In lead 3, which is a contiguous lead, you can see the same thing, and in AVF, you can see this is the TP line, and you can see, and it's there. So 2, 3 AVF, you can see this is an ST segment elevation. I can see some people are raising their hands. I don't know whether we should take some people raising their hands. Please, if it's a mistake that you raise your hand by mistake, maybe you should put it down. Okay, but otherwise, put your comments in the chat box or in the Q&A, and we'll take them. Yeah, thank you, sir. Dr. Olagoldin has seen them in 2, 3, and AVF. Exactly. So this is an acute MI, and you must recognize this. You must recognize this. It's critical for the patient's life. Okay, let's look at this other one. Can anybody see anything here? Can anybody see anything here? This is another ECG, also from our center. Real life ECG. So put in the chat box so that you can see whether you are following. Yes, the slides we made available after the webinar for those that want to get the slides. We only ask that if you are using them to present, give appropriate credit to whom credit is due. Okay, fine. Fine. So if you look at this ECG very well, yes, I can see some people. Let me try further. Obianuju says T-wave inversion. Where did you see T-wave inversion? You must talk about where. Okay, yes, there's T-wave inversion in V5 and V6, but you can see that there's ST elevation. See the TP line again. And you can see there's ST elevation in V1, V2, V3, V4. But more importantly, you can see Q waves. Can you see this Q wave? The first negative reflection after the P wave. First negative reflection after the P wave. And you can see the Q waves almost all the way to V5. You can also see the Q waves in the inferior lead. So this is quite important, and it's a real life case. What about this? This is a case that we just took to the cath lab and then opened up the blood vessels. So you can also see there's still some, the patient came a little bit late, by then the ST segment elevation has already started coming down. So you can see there's still ST segment elevation here, V2, V3, V4, V5.
Q waves.
Exactly, sir. The Q waves. We can see that Q wave, first negative reflection, and is there all across.
And the low amplitude, we should also not forget.
Exactly. This low amplitude, these low voltages, this already telling that there's myocardial loss. Yes. You know, the heart muscle. Exactly. It's already being reduced. So you will not be surprised if you have a very low blood pressure. Actually, we have a very low blood pressure in this patient. Can we see this one? This was in a pastor recently, came in all the way from Owerri to see us with this ECG. And straight we had to take it to the cath lab. It was in the cath lab within 50 minutes. So we tried to beat the international time. Now you can see the TP wave again. You can see the ST elevation. You can see it there again. V2, V3, V4, V5, and you can see the Q waves. Q waves here, negative, negative, all the way coming down. So this is quite critical for us. So if you have any question or comment about this, please put them in the chat box so that we can answer them. Let me look at the Q&A.
These are real life ECG. And one of the reasons why we're showing this is to dispel that assertion that myocardial infarction is not common in blacks.
Exactly.
Please.
It is very common.
These are live ECG of Nigerians.
Dr. Daphne, can you comment about people say that myocardial infarction is the heart attack is not common in blacks, but it is remote control from the village.
Yeah, thank you very much, Dr. Seko. Excellent work and very interesting ECGs. Myocardial infarction is on the rise in our environment. I think it is there. As we said, we are seeing it every day among Nigerians. And the pattern is that young age group is also involved, not just only 60 years and above. Remember, that was yesterday or day before yesterday, one of the person that had a stent to the proximal LAD. That guy is 40 years old, around 40. Yes. So we are seeing it at earlier age. So the evidence speak for themselves. So I think
the patients we did that had triple vessel disease, 3 vessels blocked, they were all around 40, 42.
Yeah, very correct. I remember the patient. Triple vessel disease, and even this one that came from Owerri, the 3 vessels are all blocked. Yes. The one just showed the ECG. So very interesting. And the patient have his life back because the relation had their own information and they came on time. And they didn't allow any superstition or any belief of a myth that somebody is remoting you from somewhere to drive their decision. They came and they got the answer they needed, and they are very happy. And the pastor is back to his pulpit, and I'm sure it will be a very staunch message that, look, these things are real, these things are there, we should not pretend over them. Thank you very much. Very rich discussion. I'm enjoying it from here.
Thank you very much. Yeah. I think we've done justice to recognizing myocardial infarction. Yeah. So the next point is, okay, after recognition, how do we manage these patients? Are these patients that I can admit for like 5 days allowed to be stable before transferring somewhere, or do I have to take urgent decision about these patients?
So like I said before, myocardial infarction is an emergency. Every doctor must recognize it as an emergency. Doctor, nurse. In every hospital, I advocate, make sure that you have a functional ECG, and that every doctor can recognize myocardial infarction. Share our YouTube channel with other people. Share our link with other people. We'll put a WhatsApp group link. Essentially, you can put an ECG if you have a problem, interpret it on your own, and we'll assist you to help interpret that ECG. But very importantly, think of it as an emergency. Don't sit on it. Don't say, let us manage first. Let's give paracetamol first. Let us try and do some treatment. Please get adequate treatment. Now, having said that, we have about 7 goals that we consider as the goals of treatment. The first goal is to stratify the risk. How much risk is here for the patient to have a myocardial infarction, patient to have another myocardial infarction, for death following this current myocardial infarction, complications, you have to identify the risk. The next goal of treatment is to restore coronary blood flow as quickly as possible. And it's very important. A lot of people don't recognize this. But for every minute or every 5 minutes you are delaying restoring blood flow, heart muscle is being lost, which is reducing effectively the person's lifespan. Person presented with chest pain and was managed and it's, oh, we discharged you, we're fine. No, we have lost a lot of heart muscle. Yes. That is quite critical. The third one is to reduce mobility, general sickness. Then we reduce complications, and if we find any complication, we treat it as quickly as possible.
That is if we do number 1 and 2 very well, we reduce 3 to 5 greatly.
Exactly. We reduce number 3 to 5, reduce mortality, reduce the risk of recurrence, we rehabilitate. This is not something that you just treat the patient and say, okay, we're treating, it's not malaria. You must continue to see that patient, you must have a specialist follow up that patient, you must be able to recognize it and treat it. So how do we treat it? Make a diagnosis. And we'll talk about diagnosis, symptoms, ECG, troponin, biomarkers. You must get those 3. If you don't have biomarkers, make sure you know a lab near you that can do biomarkers, or a hospital near you that can do biomarkers. You can send your sample to cardio care if you're in Abuja region, and we can do the biomarkers for you. Or you can send the patient here, we can also take care of the patient. Then the next thing is to reduce myocardial necrosis and death in MI. Early reperfusion therapy, and we'll talk about a lot of these things going forward as we go.
So talking about risk stratification, what are those things we're looking for in this group of patients to be able to place them on high risk, intermediate, low risk?
Okay, so very important that you look at number 1, the age. So there are many risk models, and you can easily just use a risk model. And if you go on your phone, which has a Facebook, you should download MDCal, QX calculator, Medscape. You should download. Every doctor must have those applications
to 1
at least on your phone. And if you look at them and look at myocardial infarction, you will see risk scoring models where you can easily just put in age,
all these
heart rates, blood pressure, and it will tell you what is there. But if you have people that are a little bit elderly, the risk is higher. If you have patients with very fast heart rates and they're able to come, our target heart rate is between 60 to 70. If you have patients with tachycardia, that's also a problem. If you have patients with low blood pressure, that is quite critical as a problem also. Very extremely elevated blood pressure is a problem, but patients with very low pressure and especially presenting with cardiogenic shock are typically a very big problem that will
features suggest heart failure too.
Exactly, and in those people currently with failure of heart failure, there's a classification known as the Kidd classification, which helps to even prognosticate. Why is it important to re-stratify? It's important to re-stratify because we use the re-stratification to determine and advise relatives to counsel. Look, if somebody comes with cardiogenic shock, low blood pressure, with pulmonary edema, there's a 50% mortality chance, and that also tells you you cannot sit on that patient. You need to get that patient to an ICU.
Even as much as possible.
Exactly. Even if they appear to be looking fine, they say they are fine. The next thing they can just do. I remember patients that when I work in the government setting that we lost, they were looking fine, but they had this kidney for and we kept them in the ICU. They kept on saying discharge them from ICU, and lo and behold, something happened, and we had to intervene very quickly. So very important. If you see any of these risk factors, you can see that the mortality rate rises, and this is why clinical examination is very important. If you have just low Krebs, giving elevated S3, the mortality rate is already 13%. And this is based on studies done in advanced countries. So if patient has pulmonary edema, 33%, and patient has cardiogenic shock, 1 in 2 of them will pass. So when we're talking about management, we said do the immediate ECG within 5 minutes of arrival. Yeah. Somebody is saying, how is that possible? Well, I know in Nigerian situation is difficult, but we should aim for the ideal. And the worldwide standard is to have an ECG and reported within 10 minutes.
Do it within 5 minutes of arrival, get it reported within 10 minutes.
So that is why we keep on stressing everybody should do that.
Yes.
Now, you now make the diagnosis. Once you make the diagnosis, admit that patient to an ICU setting. That is the best way to admit the patient. Have constant ECG monitoring because you could have arrhythmias, you could have problems. There are so many things we have seen. People should go into picture. One of the patients that came from Niger State with an MI.
Yes, with MI.
Wow, he had a ventricular tachycardia, and we only recognize that because he was on a constant ECG monitoring. Then he went to ventricular fibrillation twice, and we had to shock him and bring him back. If you don't have that, you will lose that patient. It would be as if he was fine. In fact, we had done because he was eating with his family, and one night he started having a and we had to intervene immediately. So it's critical that you have ECG monitoring. Get an IV cannula because we need that for resuscitation. Relieve the pain, do the enzymes, then start with medication. And I'll tell you all the medications we talk about. Ask yourself, does the patient meet criteria for reperfusion, either medical or surgical? And that medical reperfusion, that is with thrombolytics. Yes. If you cannot get to a cath lab. So if you're outside Abuja and it may take you time to get the patient here.
At least if the patient meets the criteria for intervention, this can be done.
This can be done. If you are nearby, also try and do what you can and start referring. If you are near Abuja, you can send to us. We have a cath lab. We can get the patient into the ICU. We can get the patient into the cath lab and open up. And Dr. Dafa is always on hand to open up blood vessels whenever we are.
So the lesson is, if you are close to where you can get PCI done, it is better than thrombolysis.
But if you are not close to that, please consider thrombolysis. We do thrombolysis in patients that are presenting within 0 to 12 hours of chest pain onset. That is, their chest pain started at a particular time, so you have to find out what time this chest pain starts. Okay, so we had a patient that came in before we had the full meeting of cath lab. Patient came in the morning, had been having chest pain from 2 a.m. at night. A woman, I don't know if you remember.
I remember.
By the time we saw her by 8 a.m., we noticed that, and then we thrombolized her immediately. By the time we took her to the cath lab, the thrombolysis had dissolved all the blood, that opened up the blood vessels. So you thrombolize immediately, and there are concentrations for thrombolysis. Anytime you want to thrombolize, open up your phone or your internet or your textbook and check the criteria again. Don't assume you know it. Even me, I check every time again and again and again.
And for thrombolysis, there must be established ST segments and division. If you are not sure, please don't.
Now, there are sometimes you should also be careful. You should not give thrombolysis if the MI is caused by cocaine or hard drugs.
Yes.
You should not give thrombolysis if it is an aortic dissection, because you will kill the patient. And aortic dissection will have chest pain. We also have raised enzymes, but ST elevation may not be very classical. And so those are the times you should be very careful about giving any thrombolysis.
Okay, let's go into the meat of what to do when this patient comes as a practical.
So practically, you are in clinic now or your hospital, patient comes in. What do you do? Take care of the pain. Morphine is preferred, okay? But if you don't have morphine, use what you have. We less prefer NSAID, so try to avoid NSAID, because NSAID will reduce blood flow to the glomerulus, and that will affect, it can trigger the RAA axis, and that will worsen cardiac outcome generally. So give morphine. Morphine to cardiac arrhythmia. The right patient will vomit all over.
You can give metoclopramide.
Exactly, or Dansetron and stuff like that. Now you give oxygen. Oxygen, however, before we used to say give oxygen to everybody coming with an MI, but things have changed. Oxygen should be given to those that have clinical or laboratory evidence of hypoxemia, saturation. If you have SpO2 less than 92, consider giving oxygen. If you have normal SpO2, please, there is really no need to give oxygen. The outcome
does not offer any advantage.
And in fact, it has been considered that it may even have a worsening outcome in some cases. So we should be careful about that. Then we give nitrates. Nitrates typically help to widen the blood vessels, but you should be careful. Don't give nitrates if the patient has an inferior MI. Remember the ECG we showed that he showed 2-3 AVF? That kind of patient, be careful about giving nitrates because the blood pressure can crash. If the patient has used Viagra, tadalafil for erectile problems, sildenafil. So ask the patient, did you use any drug for your manhood? If the patient has used any drug for manhood, please don't give it. It will cause very severe hypertension that will never come back from. So you should be very careful about that.
Those already with low blood pressure.
Those already with low blood pressure should be very careful about that. Now there are other things that you can use. However, that falls within the realm of specialist care. Okay. Now we typically go straight to give aspirin and a platelet receptor antagonist, typically clopidogrel. Aspirin you give as 300 milligrams as a start dose of 300 milligrams. We prefer a chewed. Remember that patient having ulcer is not a contraindication
in this context.
Now, ulcer, the patient has heart attack, he's going to die. Please don't say that the patient has ulcer. Give the aspirin, give omeprazole, give any other thing you want
the patient first, and you will treat the ulcer later.
Exactly. So give the aspirin. Then you can give your platelet antagonist. Clopidogrel is readily available in this country, so typically 300 milligrams is enough to give. But if you have prasugrel, which is typically more potent, or ticagrelor, 180 milligrams. Ticagrelor is more potent and has is faster acting.
Yes, so because the first two is first have to be converted into the approved drug and converted into the real active ingredients.
Why ticagrelor will go straight and give some good work. Okay, so it's quite important you give this. So while you are deciding, trying to move, what will you do? These are things that you must do. Then typically give a statin. We typically give atorvastatin or rosuvastatin. and you can see the dose of atorvastatin, it is very high.
Not 10 milligrams, not 20 milligrams.
Exactly, not 20 milligrams, not 5 milligrams of atorvastatin. These, of course, we are talking about patients that you are sure what you are treating. You have gotten the cardiac enzymes in the setting of acute ischemia and a typical ECG findings. So you are sure, like we have demonstrated in the last one. Then you go on to give this. Now, after you have done this, you might give an ACE inhibitor, depending. You can give a beta blocker. Okay, but be careful if it's cocaine induced. So you have to ask, especially when we talk about MI happening in young people, ask always whether they took hard drugs. Check their pupils, whether they are constituted, maybe they are high. Very important. And then admit to the CC. Get a specialist as soon as possible, or refer to a specialized center as soon as possible. But these things will definitely change the outcome of the patient. So do them as quickly as you can.
Okay, now so we've talked about all those supportive. So now opening up or restoring coronary blood flow. So what are the ways by which you can achieve this?
Okay, so to restore coronary blood flow, there's a reperfusion strategy. This is a simplified reperfusion strategy. I think it's by Topol et al. So when somebody comes on acute MI, if you have primary PCI available, like in cardio care, go straight to the cath lab. Start your medical therapy and prepare them for the cath lab. Of course, we know that there's no insurance in Nigeria. People have to pay and things like that. So those are things that you have to consider. But where you can get to the cath lab as soon as possible. Now, if you don't have PCI available in your hospital, patient has come, start the medical therapy we have talked about. Now ask yourself, can the patient get to a cath lab in time?
2 hours.
Within 2 hours. If the patient can get to a cath lab within 2 hours, then move them straight to a cath lab. If the patient cannot get to a cath lab within 2 hours, then consider thrombolysis. And you can do thrombolysis with an ectoplasm or with streptokinase. Now, don't do it if you don't have an ICU. Don't do it if you are not going to monitor. If you do it, you have sentenced yourself to sitting about that patient, watching the ECG, repeating the ECG, and doing telemetry when necessary. And so even collaborating with a specialist before that. So this is the standard reperfusion therapy. Now, if you don't have this, now if the patient presents late, or then you should now consider the medical therapy and then try and transfer to the capable center.
The specialist will use their clinical judgment to still determine whether the patient can still benefit from any of this PCI, because the thrombolysis is totally out of that
one that has gone. After 12 hours, typically, and unfortunately, a lot of patients present late, including medical professionals.
Yes.
One of the reasons why we are having this webinar, a lot of people present late, and that affects their outcome in the long run. Now, it's important that we also know that after 12 hours, reperfusion with thrombolysis will some little benefit, and in fact, sometimes causes more harm. Now, if we want to do PCI also, typically PCI is also preferred within 120 minutes or at most within 24 hours. Now, the OAC study, one of the studies showed that doing after 24 hours, doing an emergent PCI may not be the best approach. Sometimes you have to delay, except the patient is hemodynamically unstable or has arrhythmias or other problems or ongoing chest pain. Then you should consider doing PCI. So that is left to specialist judgment. But however, in some of those, in that large scale study, some people that had the PCI after 24 hours who were now already stable also had a negative outcome. So sometimes they had to wait and stabilize the patient completely and do the PCI at the secondary day or secondary level. I don't know whether Dr. Edafe has anything to say about this. Dr. Edafe is our interventional cardiologist of cardiac care. Dr. Edafe.
Yes, sir. Thank you very much. Very excellent discussion, sir. You are very right. The other thing is my only addition to all that have been said is the goal is for every patient to have a primary PCI, as you rightly pointed out.
Exactly.
And for those that are far off, like we give example, some of the patients we get from the south and southeast, you know that sometimes the event has been on for maybe 2-3 days. And even as at the time of presentation, there is still ongoing ischemia. You mentioned that. So in that case, that patient is a candidate for a PCI because there is still an ongoing ischemia as at that point.
Exactly.
Now, yeah. Now, even after we thrombolize in our center that are far away from cardio care, like we talk about the patient that came from Niger State, he had that chest pain lasted for 3 days, and it was on the 3rd day or 4th day he now came to Abuja, and the pain was still continuous for those number of days. And as at the time he got to cardio care, the troponin was unrecordably high. The pain was still ongoing. So that patient has a clear indication. Just take the patient to the cath lab and revascularize. Even though the 3 vessels are involved, we revascularize immediately. Then there are also issues of after you thrombolize a patient. After you thrombolize, don't say, okay, the vessel has opened up and you will not send the patient for a coronary angio. The aim of thrombolysis is that after the distance between the hospital of presentation to the cath lab capable hospital is longer. So you should not wait, just thrombolize and send the patient to the cath lab. So what the message we are trying to pass is that after you thrombolize the patient, and even there is a successful thrombolysis, still send the patient for a coronary angiogram to know what actually happened in the coronary tree. So it's an excellent discussion, Dr. Seko. I hope we are all learning, and I too is also learning. Thank you very much.
Thank you, sir. Thank you very much. Thank you very much. So just to look at what a coronary angiogram looks like, essentially, once the patient comes to the cath lab, and this is just a demonstration video, what happens is that we go straight, this is like examining what's happening in the heart attack. You know, the place has narrowed, a plaque has ruptured, and that has caused a myocardial infarction. So what we do essentially is to continue. We set an IV line, we put some sedatives, we take the patient to the cath lab, we pass a catheter from the femoral artery or from the radial artery. It goes up to the heart, then we engage the coronary vessels, and this is quite done within 15 minutes. The patient is fully awake. So the patient is not having any. Then we pass a dye. Patient is not anesthetized or unconscious, except the patient came like that. So this is essentially what happens during the procedure. So we now put it in. We give in a dye, and the dye now outlines for us the different coronary vessels. So if you look at this one, you can see how it comes up like that. Then we can identify where the blockage is. For example, like here, you can see the narrowing there where the arrow is showing, and that now helps us to proceed. The catheters are specially made such that when we carry them in, we go to the left and we check the right as well. Exactly. So this shows the right coronary artery. This is essentially what happens in the cath lab, and the procedure typically takes no more than a few minutes to do. Dr. Dafe, do you have anything to share about the procedures as well?
Yes, very correct, sir. Very correct. So let me just, if you grant me, let me just show two slides of STEMI, one slide of a patient with STEMI, another one with a patient with not STEMI.
Please go ahead and share your slide.
Okay, sir. Disabled, host disabled participant screening sharing.
Try again.
Okay, sir. Oh, beautiful. So let me go to, yeah. Just 1 second. I will just go down straight to, let me go for, yeah.
So it's very important that we get the patient to the cath lab, and then so he's going to show us some videos of cases we have done here, you know, to show you what it actually looks like. Typically within 90 minutes. Okay, go ahead, sir.
Okay, yeah. This is one of the patients that came in. We saw him, and the ECG was also in keeping. So we, Dr. Seko convinced us that we should go ahead and put this patient to the table. Only for us to notice that is, I hope my cursor is showing.
Yes,
Yes.
it's showing.
Yeah, this is where the block is. Now looking at it, this is the LAD. Then you have another vessel. Unfortunately, this is a very young Nigerian. You remember the guy, Dr. Seko, he has a ramp that is coming this way, the LAD. Then you have that there is a tight block here. Then the next that we did for him was to pass the wire. This is where the block is, where the cursor is in the mid circumference. Okay.
I hope you
Okay.
can see the blockage.
Yes. So this is where the PCI is ongoing here, trying to revascularize him. PCI is still ongoing. We first of all use a balloon, and we prepare the lesion before the deployment of the stent. And this is post-stent deployment. You see the vessel revascularized. This is for a patient with who had a STEMI, and later on he had a recannulation. That was that story of that patient. Now we revascularize it for him, and the guy is very fine today. The second case is, you can see that there is a total block of the LAD just at the proximal end of the LAD. You can see here, see the vessel here totally blocked off as a stump. At the mid LAD is a stump off here. It has a marked SE segment elevation in this group, in this patient. Then look at what happened. This is when the PCI was ongoing. PCI ongoing here, where we are trying to balloon. First of all, we balloon after the wire was passed through using the
So if you can just stop, Dr. Dafe, let me just show. Can we all see this balloon showing up here? That is a wire. Look, I want to go back to that slide. To that
yeah,
balloon.
Let me go back. Yeah.
So can you see this wire there? That is a balloon where we pass a PTCA wire across the region. If you look at the center of the wire, you see a darker area. That's the balloon that is right there. So what we do is that we now put in something in, blow up the balloon, and it expands the vision.
Very
so
correct. Yes, sir.
So I hope everybody can appreciate this. So this is typically what happens in the cath lab. To expand in this place, that place was completely blocked. Okay, you can go to the next one. And then we now put in a stent using the same procedure.
So after a stent was deployed, and this was the final results. The guy is fine and is doing very well. So STEMI revascularization completed, flow restore, and the guy is very, very fine. So
I hope everybody can appreciate the difference between when it was completely blocked and now that it is showing completely, and the blood vessel is showing all the way down.
Yeah,
so it's quite important. Dr. Dafe, before you go, there's a question here. What is your hospital policy in deciding whether PCI or cabbage is indicated in a three-vessel disease or left main stem disease? This is by Dr. Isa, a cardiologist.
Very good. That is a question that has been ringing up and down. Very good, sir. I just returned from the Euro PCI, and Dr. Isako, thank you very much for signing me for the Euro PCI. There are cases that were shown live in Euro PCI. Most of those cases are complex, because any case that will be accepted for that caliber of a meeting has to be a complex case. Now, the issue of cabbage and also issue of PCI, there are many trials that have been on, that have went on over the years. We'll talk about the syntax trial, which brought out the syntax score. The syntax score has to do with something of, if you have a score, each of the segments of the coronary arteries are all scored. You can get these scores online. If you have a score that is less than 22, that patient is a candidate for a PCI. If you have a score that is between 22 and 32 or 33, that patient can go for PCI or he can go for cabbage. If you have a score that is above that, above 33, that patient preferably should go for cabbage. But the question now is this: a patient may have a score that is above 33 because of maybe triple vessel disease. When you atomize the score together, triple vessel disease, you have a score that is above 33. Then another issue now is that the patient may not want cabbage because they told him it's surgery that you need to open up the sternum to get to the heart and take some vessel and attach to your below the point of the block. But the patient may say, no, I would like PCI. So the patient will likely go for PCI because that is a preference for that patient. Then another thing again is that you also depend, not just saying that it's 3 vessel disease and you go for a cabbage. If the stenosis are, they are tubular stenosis, they are something that you can settle with stenting, I will still ask that go for coronary stenting and PCI. But if it is a diffuse lesion, you look at the 3 vessels, the ROCA, multiple lesion in the ROCA, to the point that when even after stenting, you will still have many lesions unaddressed. In that case, you will not say this patient should go for a cabbage. Then another thing again is that the capability of the intervention is also determined because yes, exactly. The cath lab is meant for complex interventions. So if you have that capability to address the complex intervention, like the man we showed from Owerri, there's one of the man from Owerri that have the 3 vessel disease. We address them, we put stents and address the 3 vessel disease for him because he has an acute MI and the 3 vessel disease are clear that we can address them. So we address them. So it depends on the capability of the interventionist at that point. Then also, there's another one, the one that came from Mina, also had 3 vessel disease. Even on the cath lab table, immediately after the angio, which took us about 5 minutes, the guy has he had a cardiac arrest. We defibrillate him, shock him, and return him back. We still stent him, and the man is very fine today. So the question is the capability of the interventionist and deciding what you can do and what you cannot do. Then also, you also take the concept of the patient. This, do you want us to go ahead and do and offer a PCI for you, or you want a coronary angiogram? So it's a team discussion. Like in the cardio care, we have the heart team discussion. So we agree this is what we should go for and this is what we should not go for. Considering that line,
essentially it's a multifactorial decision. Number 1, the patient's consent. Yes. What does the patient want? It's very important in this era of patient-centered care. Number 2, is the patient going to be able or willing to go for cabbage? A lot of patients absolutely do not want open heart surgery. Yes. Number 3, is there ongoing ischemia and is the patient likely to die before you get that open heart surgery? For example, the last patient we had on the table that had 4 vessel disease had a ventricular fibrillation and cardiac arrest. Yes. While we were there, we shocked him and came back. We cannot say we are keeping that patient for cabbage because the patient had already been on high dose clopidogrel. So you either take him straight for cabbage, and the patient relatives were not ready for that surgery. And if you don't do it, the patient goes. So you take the consent, take a group to show the family, and the 2 cardiologists or more, and we decided to put in 3 stents, and the patient is fine and has gone home today. So those are some things that we consider before deciding which way to go. So if you look at this angio also, you can see the blockage there, circle there, right there. So it's quite important we put a stent across this one, and that typically solves the problem.
Yes. So I think we had a very, very wonderful discussion, telling us what is possible, what is doable, and what we need to do. And I'd like us to go to about this, talk about this time, emphasizing the fact that timing is very critical in this group of patients. Like they say, time is neuron. The same way time is muscle when it comes to the heart. The longer you delay, the more heart muscle you lose. So by the time you are keeping the patient for about 6 to 12 hours without any intervention, there's almost a permanent loss of the myocardial muscle.
And it's very devastating.
And it's very devastating.
Patients come with heart failure, they cannot walk again, they can't go out. And remember that we talked about Nigeria being peculiar, and a lot of people are 40-year-olds, and cannot a 40-year-old man having heart failure cannot do anything. You know, it's quite difficult. Even at home, cannot walk with the wife, and it's difficult, cannot go to work. You know, it's quite difficult and devastating.
So I think it is critical to say, once you are able, with your clinical judgment, ECG, have a high index of suspicion that this is likely going to be a myocardial infarction, I think the next thing is to refer to a specialist.
So somebody was asking, can we give the dose of, what is the question again? Thank you so much. What dose of fibrinolytic is used? And can you please list the post-MI care plan usually drawn up for patients? So in terms of post-MI care plan, that's a full lecture on its own. But suffice to say that post-MI care plan is a multidisciplinary approach. Typically, what we do in our center is to have a combination of excuse me, physiotherapists, cardiologists, the nurse, pharmacist, social worker. And the idea is that you need to get the patient back to be able to walk again. So you slowly do cardiac rehabilitation to get them to exercise again, to do different activities again. Then somebody has to follow up on them in terms of care and medication use. Patients will always, especially men, will ask how soon can they resume driving, how soon can they resume sexual activity, and all those will involve what you do in terms of the rehabilitation.
Yes, and then management of the cardiovascular risk factors.
Exactly, critical. You now have to make sure that you control the blood pressure, the blood sugar, the lipids, cholesterol. Like the last patient we had very terrible left main stem disease. He was smoking heavily, and even when he had the first one, we were able to stent the major vessel. Left main stem came the next time. He said even though he has stopped smoking, he still stayed around people that were constantly smoking. So you have to watch out for all those risk factors. This is where sometimes the social worker has to go to the home of the person, work with that person. That is typical for the post-MI plan.
Antiplatelets use.
Antiplatelets use. Now, if the patient has had a stent, the patient must. How many times did I say must? And must be on dual antiplatelet therapy. Okay? Because if you don't do dual antiplatelet for a minimum of 6 months, please, the patient must. Don't let them come to your clinic now and say they have one ulcer-like symptom and you stop the treatment. No, don't do that. They came to your clinic, they said they've had a stent before, and they said, no, move aspirin. No, don't do that. Give them the treatment for the ulcer and let them continue the aspirin. The 10 times when you might stop aspirin is if the patient has a true aspirin intolerance. Not just that they have ulcer. No, you treat it and they must be on that antiplatelet therapy. It's quite critical while you are controlling all these other factors. Then, of course, if there are any complications, a lot of patients have come in late, they already have heart failure, you must also address it. And that will involve echocardiography, that will involve BNP monitoring, that will involve follow-up with the cardiology clinic and checking of weight, amongst other things.
So it involves a lot of people. The dietitian might need to come in, like you said, the physiotherapy, you have to assess their exercise tolerance. You need to put them on a treadmill to assess something. So it takes a whole lot of people to manage the patient post PCI, especially for them to get back to near normal activity. If it's not normal, to get back to normal activity.
Dr. Dodi Emmanuel, from Port Harcourt, I can see your hand is raised up. You can talk. Just unmute yourself and talk. Dr. Dodi Emmanuel, you can talk. We've unmuted you. Unmute yourself and talk, Dr. Dodi Emmanuel. I can see your hand is raised up, so you can talk. Or maybe it was raised up mistakenly. Dr. Sutoye Dodi Emmanuel from University of Port Harcourt. Okay, fine. Gregor Williams, your hand is up. You want to say something? You can unmute yourself and talk. That we can have other people talking in. Okay, fine. Let's look at the question. Somebody asked what the full meaning of MINOCA. MINOCA. Just like it is, it's an abbreviation. Myocardial infarction is non-obstructive coronary artery. So you do the coronary, angio. Patient had every feature of myocardial infarction. You do the coronary angio, and you don't find it. You still will continue medical management of myocardial infarction, but in this case, it's myocardial, it's a recognized entity now. Now, in patients that had COVID, they also gave us some problems during the COVID period. Because in COVID, troponin could be elevated, they could also have ST dimer, ST elevation could also occur. And then, is this myocardial, is this COVID? So that has put a new dimension. But papers were coming out every week with different modalities of, so I'm sure we will still have new guidelines in relation to COVID and how it affects myocardial infarction. So what are you talking? Somebody said, thanks for spreading the knowledge. How do you reach out to NMA? Well, we give out all these seminars, webinars free. Anytime NMA calls us, we're also ready to give to NMA. Talk about this one. After revascularization, what measures do you take to prevent recurrence? Okay, so after revascularization, there are several measures that you take. Now, there are several studies that have been done. What type of antiplatelet to use? What kind of thing? And we've talked about the post-MI care. Number one, we take care of the cardiovascular risk.
Yes. Important.
Blood pressure, diabetes, we give antiplatelet therapy, lipids, we follow up the patient. We follow up the patient on other things in terms of smoking risk, alcohol. We take care of that. That helps to prevent recurrence. Some patients, however, may still have, problems nonetheless. Yes. So despite all of this, some patients may still have some of these things. Now, it's very important that anticoagulation is also part of it, especially to reduce stent thrombosis. So you pass the stent, you are opening, hallelujah, and you're not doing correct medications. Or some patients went somewhere, and somebody told them, stop all their drugs, you have been healed miraculously, and they stop their drug and come back with stent thrombosis, and it's a nightmare to deal with.
And because of the presentation, some patient might actually come back with complication. Exactly. So remember the retired military officer that came back down with ventricular aneurysm, very bad heart failure after a failed reperfusion.
Are there any special considerations for MI in pregnancy? Dr. Edafe?
Yes.
Maybe Dr. Edafe to help us with this one. Are there any special conditions for MI in pregnancy? Let me check if Dr. Odunuko is around.
Okay. The issue of MI in pregnancy, it can occur, but the question is that if it occurs, one thing that you look at is that will you be able, because you don't want to expose the unborn baby to radiation, which usually occur during PCI or during coronary angio. So if you weigh the risk and you feel that the patient's life is more, you have to save the mother's life, and if you don't intervene, the mother will go. What you do is that you can go ahead and intervene, but while doing that, you have to shield that area where the pregnancy, if you shield it off with a lead apron to see that there will be no radiation to that particular segment of the mother. The another issue again is that radial route will be better here, so that you will not use femoral route, because if you use femoral route, you expose at least a part of the groin. So you prefer to use the radial route here. Hello, sir. I think we are we here? Hello, sir.
Yes, we are here. Sorry, we had
very good. Very good.
Problems initially.
Yeah,
but I heard you heard that, of course, in pregnancy is a very significant one. It's a direct one, and it's something that we must take both with the obstetrician and the cardiologist at the same time. And of course, the problems, of course, is taking patient to the cath lab and doing angio. You have to shield. Also, the problem of thrombolysis.
Then drugs, reactions, maybe.
Yes. Then the radial route is preferable to femoral routes.
Exactly. The radial route, of course, preferable to femoral routes because of the obvious problem of getting hemostatic control, access, pressure going down. Yes, so I think that is quite important for MI in pregnancy. I have not seen any case of MI in pregnancy yet.
I have never seen, since years of doing coronary stenting and angio, I have not seen.
It's something that is a rare finding, and I think there will be theories relating to several things that happen in pregnancy.
It's very rare.
I think our God is very good in that regard.
Yes.
Okay, should one
worry
about
first degree heart block?
Okay, so maybe Dr. Alison.
First degree heart block is a common thing we find in a lot of people. So asymptomatic first degree heart block, I will not worry, except if the PR interval is significantly prolonged. But in most first degree heart block, I will not bother. It's found in so many people. So you have a PR interval of 0.22 seconds, 0.25 seconds, where we're not bothered. But when you have significantly prolonged, most likely the patient is going to have some symptoms. So maybe you can now send the patient. But first degree heart block, asymptomatic, there's no need to panic.
Somebody is asking, is there any relationship between MI and blood pressure? Is there a relationship between MI and blood pressure? Of course, blood pressure and hypertension is one of the most significant risk factors for myocardial infarction in Nigeria as of now. There are definitely likely to be other things which we are still investigating. But blood pressure, hypertension, and diabetes are quite important. Also, when a patient has a myocardial infarction, several things can happen. Due to sympathetic discharge, blood pressure can shoot up in that active event, and due to the pain. Also, blood pressure can go down, like we talked about the clinic classification, in which case the patient can have hypertension and be quite sick and have a high risk of mortality. So it's one of the things that is very possible in myocardial infarction.
I saw a question about cost effectiveness of PCI in patients with myocardial infarction, and I think it's like asking what is the cost effectiveness of saving a life, because if you don't do anything, you will likely lose that patient.
Definitely, if you don't do anything, you will likely lose that patient. And even if you don't lose the patient, the cost of morbidity, the patient not being able to walk again for the rest of their life, heart failure, repeated hospital visits, repeated admissions,
which you're still going to spend money on, and eventually we still end up losing.
And in most cases, cath labs in Nigeria are quite relatively cheap compared to what obtains outside the country. So the cost, assuming if that dollar price is very is less than 20%, 30% of what.
By the time you factor all the costs, travel, accommodation, and even all other non-medical expenses,
that is quite significant. Yes, most angiograms cost between 700 to 800,000 or something like that, and most stenting costs between 1.5 million to 2 million thereabouts. So it's quite significant, and that is why the role of insurance or role of donors is quite important in treating this medicine.
Yeah,
so
Dr.
Other questions now.
Dr. Naliko. Hello, sir.
Please go ahead, sir.
Yes, the issue you raised about cost effectiveness is very true. You remember that that patient that went to Dubai had a dual chamber pacemaker at just only the procedure cost him $20,000. That was the information he gave to us. That was more than a year ago, and the device got infected, and he called them, and when he called them, they charged him for, first of all, they are going to put another device for him, which will also cost him another $20,000. Then they will also take that device out. Extraction of that device will cost him another $20,000, only for him to come to cardio care and got it everything. I mean, both extraction and the implantation of a new device. Far less. How much is it? Is it $5,000 or thereabout? That costs him everything. So cost effectiveness in Nigeria is absolutely very, very low. There is also a call that the insurance company should come in. The insurance scheme should come in and invest in this area so that more people and more clients can be brought into the picture at no cost to their pocket after paying for insurance for their hair care. So you are very right by saying that cost effectiveness is very is still low compared to what people get outside Nigeria. And another thing again is that the procedures and the techniques and the people doing it, I don't think you have anything better when you go outside compared to what you are getting in Nigeria here. So we should have confidence in ourselves and take these procedures in Nigeria instead of traveling to South Africa, traveling to India, and spend extra money, which is not warranted. Thank you very much.
Okay, sir. So we have a question here. How do you manage acute coronary syndrome in normotensive patients or in patients with hypertension?
Okay, so what we do is simply the same thing. It doesn't change much. Only that you should be careful. If patient has hypertension, we already said be careful about nitrates. You should also be careful about beta blockers. Now, when you have a patient with acute coronary syndrome, one of the key ways to manage them is to get them in the ICU setting, where you can have invasive blood pressure monitoring, especially patients that have very low blood pressure, or to manage them in a HDU setting, where you can be looking at the blood pressure as you're monitoring. So when you make any changes, you can see the, so it's quite important. The same thing, we do the perfusion, we do the morphine for pain, give oxygen as necessary, aspirin, statins. So whether the patient has low blood pressure or not. Now, if the patient has a low blood pressure, now that now becomes a critical case. That's not the case that we can manage in a GP setting or in a setting without full ICU support or complement. So you have to refer the patient. So the dicey part of using inotropics or using devices. Now, one of the things we use in cardio care, which we have just taken receipt of, is to use an intra-aortic balloon pump as a bridge to your cath lab. So you take that patient to the cath lab, you put on an intra-aortic balloon pump. The aortic balloon pump essentially is a device we put into the aorta. It helps to complement the contraction of the heart. When the heart contracts, the aortic balloon device also synchronizes the ECG and helps to push forward blood. That helps to push up the blood pressure while you intervene. So that is a very high risk case, and it's something that it must be done with utmost care.
Another thing is how you're going to use your ARB, whether you're not going to use, whether you are going to use that to reduce dose, your beta blocker. These are other things that your blood pressure will also affect. So you need a good judgment by a team of specialists to be able to manage patients, especially in that regard.
There is a question about troponin, and somebody says he missed the point of troponin and how to interpret troponin. What we say essentially is that troponins typically increase after 6 hours. So if a patient comes to you with chest pain with a suggestive ECG and troponin is negative, actually did the ECG within 1 hour or so, it is not time for you to send away. Myoglobins will typically give you an earlier.
That would have been the best in that.
Exactly. Patients still come in very early, and then you can now start your treatment. So it's very important, and it peaks in 1 to 2 days and reaches BMI level. Sometimes we've had patients here, and they are typically very bad, that have troponins that are so high that it's unrecordable. That is quite critical for us in this regard. Now, there's already some highfalutin stuff about highly selective troponin, but I think we'll not have enough time to do that. But what I would just say is that a single troponin tip concentration after 72 hours following an acute MI has been found to be very predictive of the MI size. So if you have somebody presenting like we had a man presenting about 2 or 3 days with very high troponin, just like the last patient that we talked about, definitely he had what we expected. 4 vessels were blocked. That typically helped us to show, and we were prepared for the eventuality happen to resuscitate him if anything happened, and he's fine and he has gone. And independent of reperfusion, that is that. Now, if patient has a very elevated troponins, they have a higher mortality rate, they have more thrombi typically, and they are more likely to have depressed function. Now, when you're interpreting the troponin, if the patient has already had a PCI, so sometimes the patient has a PCI for his end, and the patient has the troponin will be high because of that PCI. If you are trying to interpret that, for that one, you need at least 5 times the upper limit, or 20% increase in it, which was elevated. If, however, the patient has finished cardiac surgery, so it's not impossible for patient to finish cardiac surgery and come back. For those kind of people, You need it more than 10 times to be able to determine that you have a significantly elevated troponin level in this kind of group. And this is why the new definition by the consensus group from 2007 tried to subdivide it and do what is called the universal definition. All the society of cardiology have come together and agreed that this is the definition that we all agree on, and it's universal. And it could be as a result of any of these ways to look at the troponin.
So doing your troponin is very, very critical. Serial troponin check and subsequent follow-up of troponin. So it's not just a 1 point or a one-time troponin, 1 point, 1 time ECG. So because all these things are dynamic.
So somebody is asking about left ventricular support in left main stem disease. Of course, yes. Typically what you have to do is, number one, left main stem disease, you have cardiac backup, cardiac surgical backup. And if you don't, you must make sure that you do what is called a protected PCI. You have some support with impeller device or IABP like I talked about it, you have here. And then you can now go on to consider doing it. If you are unable to do it, then, or you consider that the benefit outweighs the risk outweighs the benefit, then you should consider pulling out for a surgical intervention. Okay. Is there any other question we have not answered? The slides are available, and you get the slides via email. All we ask that if you have to use the slides, please give appropriate credit. If you look on the chat box, a link to a WhatsApp group has been there. So if you click on the link, you can easily join a WhatsApp group where we put in papers, we put in support, we put in ECGs. You can put in your ECGs, confusing ECGs, and we can help to answer the questions that are there. So if you just click on the link, you can join the WhatsApp group there, and that will help a lot. So
and you can also call ahead if you have any patients that are suspecting. You can send ECGs, you can call us to discuss, and even if you're sending patients, you can call us ahead so that you will be better prepared to receive your patients. We get patients from every part of the country, from south, southwest, northeast, north central, Abuja, and we are easily approachable. Once you put a call to us, we'll discuss and we'll get your patients the best care for them. And also to remind us that the next webinar will be 2 weeks time.
2 weeks time.
On the 11th of June.
11th of June, yes.
And we'll be talking about evaluation and management of diabetes in pregnancy. So we're going to have both the physician and the endocrinologist and the obstetrician available to discuss this topic. So we still have some questions.
If you look in the chat box, you can see that there's a YouTube link for videos of different seminars that have been done in the past, and all of that. Also, to note that when we're discussing that, we say patient came from Owerri, or came from Enugu, or came from Bauchi. Those are cryptic. They are not the actual places. We disguise them so that you cannot identify the patient. So it's not the actual patients may have come from. So and also no names are put on any of the ECGs. That's quite important. So if you click on the link in the chat box, you will see other webinars that have been presented on chest pain, on how to manage hypertensive crisis, on how to manage stroke, on what again?
I think we've done asthma.
We've done asthma, COVID, breathlessness, how to evaluate breathlessness, how to manage insulin therapy in diabetes, peripheral vascular disease. So it's quite
pediatrics presentations, O and G. So there are a lot of educative lectures on the YouTube which we can benefit from.
Yes, please. So subscribe to the YouTube channel, and then you can easily be notified anytime we upload a new video. So Dr. Dunukuma, is Dr. Dunukuma around? I don't know if he's able to make it. I know that this is I think it's 4 a.m. in his time now. So I was hoping he could join us up and give some insights. Are there any other questions that we have not answered? I can see some people's hands are raised. We'll be closing shortly. So if you have any questions, just put them Dr. Oshunlaja, Tafa Oshunlaja, do you want to go ahead? Go ahead. I omitted you. You can unmute yourself and talk, Dr. Oshunlaja. I presume he's a doctor.
Yes.
You know him.
I think the name sounds funny.
Hello, can you hear me?
Yes,
Yes,
you
you
can.
can.
Okay, thank you very much for the job well done. It's very interesting attending this webinar. But I want you to kindly shed light on reperfusion injury and how can one deal with it?
What did you say? Reperfusion?
Reperfusion injury.
Injury, and how can we deal with it?
Oh, fine, fantastic. Thank you so much.
Thank you.
Okay. Okay. Dr. Dafe, do you want to go ahead with that? Should I? Hello, Dr. Dafe. He's not talking. Okay, so reperfusion injury essentially occurs by the time you have opened up the blood flow. I don't know if we have a slide on that. Okay, by the time you have opened up the blood flow, and sometimes we see it in the cath lab. And what typically happens is that there's release of free radicals, oxygen free radicals and the like, and that typically causes a lot of problems, ranging from arrhythmias, and sometimes we have some other problems like low reflow in the cath lab, which we have to address immediately. So those reperfusion injuries, essentially, most of them we manage conservatively. Most of them. Do you have any other things we normally do? But most times, I don't think we had only one case.
Yes, just one.
And in which case we managed conservatively, observed, we treated the injury, the arrhythmia as we're seeing it. Yes. In that case, we had opened up with the cath lab. Now, what we do here is that because we are hardly using thrombolysis, because we have a cath lab, we always do primary PCI as much as possible. So just in a few cases, we have to do thrombolysis. So in such a case, we get to see, we have already opened up the blood vessel and we are sure about reperfusion. Now, if you want to be sure about reperfusion, I think I put it here. If you want to be sure about reperfusion, there is no single criteria to determine whether a patient has had reperfusion. However, there are several things. One is repeat ECGs. Repeat ECGs can show ST segment depression. That will help you show that there's reperfusion. Number two, there are some arrhythmias, and notable among these arrhythmias is an AIVR, idioventricular rhythm. That also can show that the patient has had a reperfusion. And then the patient's chest pain could sometimes be used. If you have, although it's very inconclusive. Now, if you have reperfusion, if you have all of these, typically it gives you it's highly specific that you have a successful reperfusion. Now, injuries that will occur typically will come in the form of arrhythmia mainly. Now, if you have an arrhythmia in form of ventricular tachycardia or ventricular fibrillation or whatever, treat in line with the ACLS protocol. That's what we typically do. Follow your ACLS protocol and treat. Now, what we also have here, which luckily we have, is a temporary pacemaker. So sometimes when we have that bad bradycardia that will happen, we can put in a temporary pacemaker. We had a Caucasian that came in once with post grafts. Now we open as soon as we started the angio. In the process of doing the angio, what we think perhaps is that maybe because we did not see the blockage per se, maybe a clot dislodged or he got reperfused. He had entered a heart block, and immediately we put in the temporary pacemaker. Checked again, we did not really see where the blockage was, which is one of the reasons why things like Myocardial have been considered. And then we went on to put in a permanent pacemaker because even despite adequate treatment after 24 hours, still the patient did not have that. So that's what we have done in the Nigerian setting. Now, I'm sure there are other approaches that have been done in other settings, but this is what we have done in our own setting here. Yes, I don't know if there are any other questions. Dr. Williams. Okay, I don't know if there are any other questions. So, in the absence of any other questions, can we do a poll? We are launching a poll. Please just assess. There are 122 people on the call. Our 150 have been on the call. Some have left now. Just click on the poll. Go ahead. Click on what you think is the most appropriate answer. The first question says, which of the following are not used as part of diagnosis of myocardial infarction? Number one, abnormal ECG. Number two, abnormal blood pressure. Number three, abnormal troponin levels.
Single option, not multiple choice.
Go ahead. Let's try. Attempt the question. Which of the following is not used? Which one is not used? So attempt.
As part of diagnosis for myocardial infarction.
Okay, I can see people clicking. Good. Good. The second question is typical precordial chest pain. Means, can we answer them? And the third question is, what is the standard cutoff time for doing an ECG in the patient presenting to the ER? So we have 3 questions. Answer. Don't worry, the answers are anonymous. I will not know who answered what. I will not also share who answered what. Okay, fine. Can see a lot of people. Yes. We have 122 people on the so far. So let's
about 125.
Yeah, 125 that are still available. We had about 150 for this presentation today. So we believe that we are making progress. So answer all the questions. People have answered question 1. Go to question 2. Just scroll down. You see question 2 and question 3. Let's answer them. Let's answer them. And let's see whether we have been able to do a fairly good job. I should have asked a question. If you don't have an ECG, what can you do? How do you cope if you don't have ECG and cardiac enzymes? How can you help in the myocardial infarction? What should you do? Maybe that's a very good question.
Transfer the patients.
Okay, fine. I think we are up to 46% of people have voted. Anybody please voting? We are stopping voting in the next 10 seconds. 50% have voted. 51%. Yes, go ahead. Answer the poll. Please answer the poll. That is a very useful way for us to determine whether you attended and that your CME can be very valid to be given to you. So if you don't attempt the poll, we might think that you just connected and you just want CME. Our goal is not just for CME, it's to make sure that we actually got something. So I think we can end here and look at the answers. Okay, so these are the results. Most people chose abnormal blood pressure, which is the correct answer.
Yes.
So we said abnormal ECG, abnormal troponin levels, and chest pain, all evidence of ischemia. So this is the one that you don't need. When you're making diagnosis of blood pressure, it may be high, it may be low.
It may be low, it may be normal.
But it doesn't mean that you don't need it. Number 2, say typical chest pain means precordial chest pain, which reduces with rest and increases with exercise, etc. Remember the 3 criteria we said, and we will try and send you the chest pain algorithm so that you can use it in your clinic. So very good, 87% of people got it. So I think I'm a fair well. Dr. Edafe and myself we have done a good job. Dr. Alale, thank you so much. They got the message. Now, what is the cutoff time for doing an ECG to the patient with
the important word here is doing the ECG, not reporting or interpreting the ECG. So,
and remember, we said that the ECG should be done within 5 minutes and then reported within 10 minutes. Okay, that's what we said as should be the criteria for standard ECG. And we said that it might be difficult in this country, but yes, those are some of the things that we have to do. So good. I'm very happy with this. It shows that we have done it. We followed very well. Okay, thank you very much. Thank you for joining us. Once again, it was brought by Cardio Care. This is what the cath lab looks like. In case you are wondering, there's a C-arm there. We pass it through this. We have residents there, and we look at it. Patient is awake, and we are able to open the blood vessel. If you are in a town, locate the nearest cath lab close to you, and the cardiologist you can speak to if you are far away. But of course, Cardio Care is able to get patients from all around the country. Thank you so much. Our next webinar is on diabetes in pregnancy, evaluation and management of diabetes in pregnancy. It will be mind-blowing. Dr. Alfonso is already doing press up, and Dr. Nicole, they are doing press up with the stuff that they are going to move. So make sure you don't miss it. And if you check the chat box, you will see the link for somebody has posted the link for our WhatsApp group, which you can join up so that you can get information early. We easily post slides there, and then it's easy to reach us if you have any questions. After now, if you have any questions, you can reach us, or if you If our answers were not produced enough because of time, we can answer them there. And then, like the PDF of how to read an ECG, 2-page PDF, we'll put it there. The PDF of chest pain interpretation, we'll put it there. And as soon as we have any webinar, we'll put it there. Also, the link to our YouTube channel is also in the chat box. So you can click on it and subscribe. Once you subscribe, anytime we post a new video, you will be notified. And there are lots of things. Just use it in your free time rather than watching DSTV. It will be very helpful to growing your medical practice. So thank you very much. We are very grateful for everybody that joined up with this webinar. And we believe our hope is that as doctors improve, that healthcare Nigeria improves, and that Nigeria, we don't have a plan B. This is our plan A and plan B.
Plan A.
So we thank you for joining us once again. I don't think we have any final questions. Thank you very much.
Have a wonderful weekend. We'll see you 2 weeks' time.
Thank you very much.